Okay, so now let's talk about airway. So let's maybe put this guy over here. But actually, it's not so much airway as we want to talk about oxygen delivery. Ultimately, our goal is we want to get oxygen to the brain, right? And to other tissues. We want to perfuse there. And the delivery of oxygen depends really on two factors. Depends on cardiac output and the oxygen content of the blood. Cardiac output is really going to be determined by how well the heart pumps. And in cardiac rest, it's really not doing that, right? And oxygen content is determined on how well we're ventilating. And that is getting oxygen into the body. And so it turns out, though, in cardiac arrest, the main limiter is going to be cardiac output. So this is the one we gotta maximize. And so this in BLS amounts to CPR. And this in BLS accounts to mouth. And so we now know that good CPR is the most important thing. Remember we talked about over here, early CPR is paramount, it's very important. And so that's why we stress that. And so that means you want to get 100 beats per minute. You want to make sure that you have chest compressions that go about 2 inches deep, sometimes 2 or 3 inches deep. And if you have to, you can kind of ignore mouth to mouth for now, with the idea being that the recoil of the chest is going to bring air into the body and therefore bring oxygen into the body, and that's enough. And that's going to deal with the oxygen content. That's enough for that. Maximizing cardiac output is going to be the main thing that gets blood and oxygen to the areas it needs to go to. But if you're by yourself, I would focus on CPR. If you need to, you could do 30 chest compressions and then 2 breaths, 30 chest compressions and then 2 breaths. Now, if you're in the hospital, so you can use the bag valve mask only if there's 2 people, let's say 2+ people. If there's just one person doing CPR, that person should concentrate on doing chest compressions, and then if you need to, jump over and do 2 breaths and then jump back over and do CPR. Futzing around with a bag valve mask is a waste of time. If you got 2 people, one person can do chest compressions and the other person can do the bag valve mask. If you have 3 people, it's even better. You can have 2 people doing bag valve mask and one person doing chest compressions. Of the 2 people doing bag valve mask, let me put a guy here, you're going to have one person holding the mask and you'll have another person actually bagging. And here's our other guy who's doing chest compressions. 2-hand chest compressions. Now, one of the worries with bagging someone is that you're introducing positive pressure into the patient, and what that might do is insufflate the stomach, thereby causing it to inflate, and then pressure can cause gastric content to come right back up, and they would aspirate that. So that's one of the possibilities, that you might have your patient vomit while doing bag valve mask. The common teaching has always been to apply cricoid pressure to avoid this, to avoid actually insufflating the stomach. If the patient's vomiting, you don't want to hold cricoid pressure because you can actually build up a pressure in the esophagus and rupture that. What you're trying to prevent is air from getting in the stomach. However, if you don't know what you're doing, pressing on the cricoid can inadvertently, you could overpress it and compress the airway and therefore decrease effective ventilations. There's a couple airway adjuncts you might want to use. The first one is called the oral airway. It's also called the bite block. Now, the oral airway can help, but you can only put it in if the patient has no gag reflex and you know how to use it. It's a hard plastic thing and you kind of insert it into the mouth. Now, the problem is if you push the tongue into the back of the mouth, you could actually obstruct the airway. Another thing we have is something that we call the nasal trump. It kind of looks like this. This is actually a flexible tube that goes in the nose and then goes into the airway. So we'll call this the Nasopharyngeal Airway. Now, this is good if the patient can't open their mouth. and so you can't stick in an oral airway. So you stick this into their nose, and it goes in and kind of stents open the path to get air in and out. Now, the one caveat with this is if you have a patient with facial trauma and you shove this into the nose, you run the risk of actually shoving it into their brain. So if someone's got a basilar skull fracture and you stick one of these in there, there's always a risk of doing that. So facial trauma, don't use the nasopharyngeal airway. Okay, we've got actually a couple of other tools we can use as well to secure an airway. But before we do that, let's draw a picture of what the airway looks like. So this is the trachea, and behind the trachea sits the esophagus. That's the epiglottis. So T is for trachea, E is for esophagus here, and this, remember, is the epiglottis. Okay, so if you're having difficulty ventilating a patient, you have a couple other tools you can use. You can use something called Combitube. And what a Combitube is, it's like an endotracheal tube, except it's got 2 lumens. So let's say this is what it looks like. So 1 lumen, I'm going to grossly exaggerate what this looks like. So you have 2 lumens that you're going to stick in, and this goes in blindly. And then what you do is you just kind of pick one, and one of them is going to go in the esophagus and the other one is going to go into the trachea. So in this guy, let's say we were going to shove this tube in him, and we're not even looking at how we're doing it, we're just blindly doing it, and we stick one tube in, and this one ends up in the trachea, and the corresponding green one then ended up in the esophagus. So we kind of guess, and we hook oxygen up to this green one first and see what happens. If we don't get chest rise, we don't get air movement, we say, well, it's the wrong one, let's try the other one. So we hook oxygen up to this red one and we see what happens, and if we get it working, then great. This isn't perfect. It's a great temporizing measure though, and remember that if someone's vomiting, stuff can still come up and you can still aspirate, so it doesn't protect the airway. So the thing you want to be careful with the Combitube is you want to make sure that you're ventilating the patient. So if you hook oxygen up to this green one and you run the code like that, this patient is not getting oxygen. So you want to check somehow to make sure. The Combitube is frequently used by paramedics, by EMS. Another device that exists is something called a laryngeal mask airway. And it kind of looks like this. It's a triangular shaped thing with a big tube on the end. So it's called laryngeal mask airway. And so the way this works is on the flip side of this thing, say it looks like that, there's the tube, there's a hole where air comes out. That's where the lumen of the tube will come out, and this whole part is a balloon that you can inflate. So there's a little port there for you to inflate this balloon. So you kind of stick this thing in, and as you stick it in, you scrape the top of the hard palate and then the soft palate, and you just follow it all the way down, and you just kind of jam it in here like this. And what happens is once you inflate it with air, it kind of fills up that whole space, and this tube sticks out. This is also done blindly. And so now what happens is, as you give oxygen through here, it comes out that hole and hopefully goes into the trachea. Again, this is not perfect, and even though the esophagus is somewhat occluded, it doesn't necessarily protect against aspiration. Now, the benefit of the LMA and the Combitube, or both of these things, is that you can do these while chest compressions are still going, so you don't have to stop chest compressions. You can establish an airway and continue chest compressions.